Thank you, Borba. Thank you so much for the opportunity to our pediatric department to have this wonderful week. So today it's a great pleasure to introduce Professor Sandip Chatterjee from India, from Kolkata in India. Professor Sandip is head of Department of Neurosurgery in Park Clinic in Kolkata, and is the actual ISPN Education Committee member. And it's a world reference in pediatric neurosurgery for everyone. It's the actual president of the Indian Society. So it's a big pleasure for us to have Professor Sandip talking at 2 a.m. for us. Thank you so much, Professor.
Thank you. Thank you. Shall I start my screen share?
Yep.
There you go.
Yes.
You can see me, right?
Yes, right.
Great. Well, thank you for inviting me to this virtual meeting. And as president of the Indian Society of Pediatric Neurosurgery, I bring you the greetings of all the members of the Indian Society of Pediatric Neurosurgery, who geographically, though far away, as you know, are emotionally very, very close to your society now for many years. It is a great pleasure to be able to talk to the Brazilian Society of Pediatric Neurosurgery. And I was asked to talk about problems with the craniovertebral junction. And I have chosen to name my topic, My Romance with the Craniovertebral Junction, from Anatomy to Anomalies. And as we go along, you will probably appreciate why I have chosen this title. The primary reason is that anatomy in this region really is the crucial guide to understanding the anomalies, which is, of course, necessary if you're going to try and treat these children. I always start off by saying that the entire craniovertebral junction is an area which is full of various difficult to understand concepts and some misconceptions. And here's the first one. If you see this man on this title slide, of course, you know this is Atlas. This is from a 14th century statue which stands still in the city of Florence in Italy. And of course, everybody thinks that the first cervical vertebra was named after this man Atlas because Atlas was asked to hold the entire world on his head. In reality, of course, this is the first misconception about this region, because in Greek mythology, Zeus asked Atlas, who was one of the Titans who had lost to the gods, to go up and support all the stars of the sky on his head. He was never asked to support the earth on his head. And therefore, this is the first misconception about this region. Here's the second. If you look at this particular photograph, that's the atlas, that's the axis. But here's an atlas which is very, very big and strong. You will notice this belongs to this creature. And the atlas of a carnivore is like that, very strong, because this is a C1, C2 area that has to be very stable. In great contrast to the first and second cervical vertebra of another creature, which is like this, and you can understand this is a creature where there isn't much stability because both these are very flat pieces of bone, and this belongs to the antelopes that the tiger hunts. And the reason for the difference in the C1, C2 joint is that whereas in the tiger there is much more stability, in the herbivores there is much more mobility. Because whereas the tiger needs a strong neck to hold its prey, the herbivore needs a mobile neck to be able to turn around and locate it from which direction the tiger is coming. And I'm afraid as far as human beings are concerned, our atlantoaxial joint is more akin to the herbivore than it is to the tiger. This is tiger country. And as I go along, you will excuse me if my talk has a lot of photographs of the so-called Bengal tiger, because what I do when I'm not doing neurosurgery is spend my time in the forest photographing tigers. And all the tigers that you see in this presentation are photographed by me over the years. Historically, we know that references to this region and abnormalities in this region were found in Egyptian mummies of 500 BC. But in reality, in fact, if you go back and look at the Old Testament and look at the first book of Kings, there is a story of King Eli who, outside his castle, slipped on the edge of a stairs, as we are told in the first book of Kings. His neck hit the edge of the stairs. His two sons came running. It is said that King Eli could not get up, could not move his hands, could not move his legs, but he was able to talk and tell his sons how to rule the kingdom in his absence before he gradually stopped breathing, in what, to my mind, must be one of the first descriptions of a craniovertebral trauma that we have ever recorded. So what I'm going to talk about over the next 3/4 to an hour is to talk about the basic anatomy and pathology of this region, to tell you a little bit about radiology, and then look at the clinical application of the anatomy and radiology to try and understand some of the problems that occur in this region. Finally, I will answer some questions about the problems in this region, and I will end by questioning some of the answers that the experts have told us about this region. So here's the anatomy. Do we really understand what is happening to our craniovertebral region every time we bend our necks? In fact, this is a photograph I took when I was a fellow in North America in the deserts of Nevada. And somehow I looked at this rock formation and I thought this was nature's attempt to teach us a little bit about the anatomy of this region. We know that the anatomy basically is that this is fundamentally one joint, the occipito-atlanto-axial joint complex, with the atlas as a washer in this joint. And we know fundamentally that there are two types of movements that occur here: flexion, extension, and rotation. As I told you, in the human being, we have to some extent sacrificed stability because we want more mobility. And we have the apical, the cruciate, and the transverse ligaments that provide us with some amount of stability, of which the transverse ligament is without doubt the strongest stabilizing factor in this region. So that's the transverse ligament's anatomy that holds that odontoid process away from the spinal cord, which is here. And very, very important thing to appreciate is that on an MRI scan, you can see this transverse ligament of the atlas. So looking at an MRI, you can actually see whether this ligament is intact or it's torn or damaged. Even on a CT scan, you can get an idea about the integrity of this ligament, because the anatomy of this ligament is that it is attached on two sides to two little tubercles. These tubercles exist on the medial aspect of the occipital condyles, and hence, if you get a CT scan which shows you that that little medial tubercle has been dislodged, that's where the medial tubercle is on the other side. This medial tubercle is half attached there and half moved here. Then that means that the transverse ligament of the atlas has torn from its attachment So looking at a CT scan, you can also get an idea that the transverse ligament is not intact. And of course, if that ligament is not intact, you've got an unstable C1, C2 area. So the main ligaments that bind this central pillar, as it were, of the odontoid process is the tectorial membrane, which is another name of the posterior longitudinal ligament, the cruciate, and the alar ligaments. If you look at the range of motions, as I said, fundamentally there is flexion and extension and rotation. The biomechanics of the OCCIPITO-ATLANTO-AXIAL complex is such that there is no rotation at C0, C1 joint. All the rotation takes place at C1, C2. But if you look at textbooks of orthopedics, or indeed some textbooks of neurosurgery, you will be told that maximal rotation that occurs at C1, C2 is 40 to 45 degrees. But if that is the case, how do you sit in a movie hall in the pre-COVID era and look at the pretty girls seated in the seat next to you? You can do that because you do not, the C1, C2 rotation is not 45 degrees, but indeed is 90 degrees. So just like this creature, we have the same flexion extension and 90 degrees of rotation in our C1, C2 joint. In fact, it was Professor Dakling Pang who, in this seminal article published in 2004, told us some of the most amazing facts about rotation at C1, C2. And the fundamental facts are as follows. Between 0 and 23 degrees, only C1 rotates. Between 24 and 63 degrees, both C1 and C2 rotate, but the rotation of C1 is more than the rotation of C2. After 63 degrees, C1 and C2 rotate in unison, right up to 90 degrees, and here the rotation of C1 and the rotation of C2 occur together. We will have reason to try and remember this later on. The lateral bending is insignificant, but what is very important to understand is that these movements, i.e. of translation and rotation, are coupled. So the dens moves up and moves forward with respect to the atlas every time there is rotation. So that's very important. Every time there is rotation, the dens moves forward and the dens moves up. And interestingly enough, long before we understood the mechanics of this region, there is an Indian neurologist almost half a century ago who, long before there were MRI scans, said that if you want to test for basilar invagination, you can do a test called the chin-shoulder test, which means you tell the child to touch his shoulder with his chin, and if the limitation of lateral rotation is less than 50 degrees, so in other words, the child can only turn his head that much and not touch his shoulder with his chin, then that's a clinical sign of basilar invagination, because as he rotates the head, remember the odontoid moves further up, and in patients with basilar invagination, that means that there is a restriction to this rotation because there is a restriction to the vertical upward movement of the odontoid. Just a little aside, remember instability is commoner in children because of poor muscular development, because of ligamentous laxity, and because the planes of articulation are more horizontal. We know that there are many clinical manifestations of anomalies in this region, and the very fact that atlantoaxial or craniovertebral anomalies in children here present with brainstem and cervical cord dysfunction, indeed with skeletal abnormalities and other stigmata, the most important of which is the short neck and the low hairline. And I always ask our residents, What is low hairline? This is also a definition that is accepted, which is that the lower hairline means that the lowermost terminal hairline in the midline, which usually is at C3, if it is below C5 spinous process, then that's an abnormally low set hairline. And when you see a child with a hairline which in the midline is below the C5 spinous process, that's abnormal. Okay, time for a commercial break. Let's look at one of the interesting clinical features with which the children with craniovertebral anomalies present: wasting of the hand. And I often ask, if you have wasting of the hand, and these muscles we know are supplied from the C8-T1 myotomes, why on earth should you get wasting of the hands in a patient with a craniovertebral problem, which is at C0, C1, or C2? Why should you get affection of C8 and T1 as a presentation? And the answer is based, in fact, on a very interesting fact of venous anatomy, which is this: for embryological reasons, the cervical cord from the C8 segment drains upwards to the foramen magnum. So here's a venogram in a child with a craniovertebral anomaly, and you can see the maximum stasis occurs at the C8-T1 segment, because the venous drainage from here is vertically upwards towards the foramen magnum. That's an interesting anatomical fact. In fact, there is equally interesting reason if you look at the lymphatic drainage of this region. And Professor Park described what's called the pharyngovertebral venous plexus with the lymphovenous anastomosis. What does that mean? That means that if the child has infection of the tonsils, this infection goes to the deep cervical lymph nodes, travels to the deep cervical lymphatics in the neck, and with this lymphovenous anastomosis, which exists between the lymphatics of the neck and the perivertebral venous plexus, the infection can go into the perivertebral venous plexus. Remember, venous drainage is from below upwards, so the perivertebral venous plexus, the infection goes upwards, ends up at C1, C2, causes the ligaments, particularly the transverse ligament, to become lax and produces a C1, C2 subluxation in a child who has an upper respiratory infection, a condition that you and I know as Grisell's syndrome. And the child can present with torticollis, neck pain following an upper respiratory infection. Even the arterial drainage, as we know, has significance in terms of problems in this region. And we know that if you look at the middle of the odontoid process, arterial supply from above comes from descending branches of the carotids. Arterial supply below that comes from the ascending branches of the vertebral. And since there is no anastomosis for embryological reasons between these descending branches of the carotid and the ascending branches of the vertebral, you will have a type 2 fracture which does not heal and requires surgical intervention. So, and the anatomy of the venous drainage, the lymphatic drainage, and the arterial supply, all of which has clinical significance when we deal with problems in this region. In fact, the anatomy of the vertebral artery and its parts are well known to most people. What you have to appreciate when you operate, particularly transorally, into this region is that the vertebral artery goes most medially at the junction of the odontoid process and the body of C2, and then goes out laterally. This is very important because it tells you how far you can go laterally when you're doing an anterior approach to this region. When you look at this same area from behind, the important thing to appreciate is V2, that part of the vertebral artery, is anterior to the roots of C2. So you can see the normal vertebral artery in a CT reconstruction, and I've put it in red so that you can appreciate where you look for the vertebral artery. And indeed, this has a great deal of anatomical significance, and this is an article we wrote many years ago. You see, that's the posterior arch of C1. That's the lateral mass of C1. And if you're going to have to put in a screw into the lateral mass of C1, your entry point has to be here, which is indicated in blue, which means you have to drill off all this bone to get there. And I'll show that to you shortly. The other interesting anatomy of C1, which I love to talk about, is what's called KIMMERLE'S tubercle. This is a tubercle which often exists on the superior aspect of the posterior arch of C1. And this tubercle is a guide to the vertebral artery, which lies just lateral to it. Sometimes, instead of a tubercle, you can have a full canal, and this is called KIMMERLE'S canal, and the vertebral artery goes right through that canal. Its anatomical name is, in fact, Ponticulus posticus, and this is fundamentally because of ossification of the oblique atlanto-occipital ligament. Just a reference, if you want to look up the anatomy and biomechanics as I've described so far, this is probably one of the best articles published in Neurosurgical Focus on this subject. Okay, just quickly about factors maintaining stability. We've told you that the transverse atlantal ligament is by far the most important. Now, what about range of movement? Flexion here is limited by the tectorial membrane and the atlantodental ligaments. Extension is limited by making the tectorial membrane taut. Axial rotation is limited by the alar ligaments getting tight, and lateral bending is limited by the lower portion of the alar ligament on that side becoming taut. It is very important, therefore, to understand that more than 3 millimeter displacement is abnormal, and it means that you do not have an intact atlantoaxial transverse ligament. So this brings us to what's the morphological criteria of instability at C1, C2, based here on a CT scan, as this particular article suggests. If you have more than 7 mm overhang, which means right or left overhang of C1 on C2 on an AP radiograph, if you have greater than 45 degrees axial rotation on a C1, C2 from side to side, if you have more than 3 millimeters translation anteriorly, and you have less than 13 millimeters of space posteriorly, the posterior atlanto-dental interval, or PADI, then these are the signs of instability. And this is the lateral atlanto-dense interval. So this is more, then that's the sign of instability. If the anterior dental interval is increased, that's the interval, that's more than 3 millimeters, a sign of instability. And if this is reduced, that's a sign of instability. I'm just going to talk about one other interesting radiological line, which I think is very much underrated, and that's the spinolaminar line indicated by this white line. Now, it's important to understand that if you have anterior or posterior displacement of C1 vis-a-vis this line, then that occurs in a type 2 dense fracture with a subluxation. It also occurs if you have a tear in the transverse ligament of the atlas. If you have an anterior posterior displacement of C2 with reference to this line, of course, the commonest reason why you have it is in a hangman's fracture. So this is a line that in children has great value, because remember that quite oftentimes you do not see all these bony structures because they're cartilaginous in very small children. And this is an X-ray I love to show because this is a lateral radiograph of this region. And it's very important to appreciate these three parts. This red line, the anterior arch, represents the anterior cortices of the pedicles of the axis. The yellow line is a composite shadow. This is produced by the cortex of the notch at the base of the dens, together with the superior articular facet. This green is in fact formed by the posterior cortex of the axis body. And this ring that you see on a lateral X-ray has an interruption inferiorly, which indicated by this white arrow, and this represents the site of the foramen transversarium of C2. So you can, on a straight, on a lateral film, get a lot of information that we don't think about. And of course, the main criteria, the image, the X-ray image that we really like to see, of course, is the transoral open mouth view, which of course is obtained like this by making sure that the inferior border of the upper central incisor is superimposed on the occipital bone. And if it cannot be seen, you change the gantry. So this is a radiology that you want to see. You want to see a good AP film, you want to see a lateral, and you want to see an open mouth film which shows you the C1, C2 joint and that odontoid process. Dynamic images are very useful here, and it's an image that I'm very fond of. And this is the standard dynamic image, the so-called flexion extension image. See, in extension, there is no subluxation. But if you look at this image in flexion, the anterior arch of the atlas is displaced significantly forward with reference to the anterior aspect of the odontoid process, and there is a huge space there. In fact, the image that we find very useful in children when you cannot be sure about an atlantoaxial subluxation is a flexion extension CT scan. And you can see here on a flexion CT, that's the narrow space available for the cord. In extension, that space becomes much larger. Also, you can see the orientation of the joint changes from flexion to extension. And this orientation of the joint is something that we will talk about very shortly. So the parameters that we know, of course, is, are the ADI, the atlanto-dens interval, but more importantly, the SAC, which is behind the odontoid process, the space available for the cord. Of course, you have all these lines, the Wankenheim, the Chamberlain, and the McRae's line. I think each one of these lines serves the purpose, but in understanding abnormal anatomy of this region, you fundamentally have to consider any line that you like to represent the base of the skull and look at the relation of the odontoid with that. Vascular investigation, as I've told you, is very, very important, but you can't do a full CT angiography in a small child because the amount of radiation that you subject a small child to is immense. So if we're dealing with an anatomy of this region, this is the standard picture that we take, which is a coronal CT with a vertebral angiogram superimposed. This can be done with minimal radiation exposure to children. And in one film, we get a coronal image, you see the joints, and you have that vertebral angiogram superimposed, so you don't subject these children to unnecessary radiation. CT scans of this region are particularly useful if you're dealing with this condition, which is a rotatory subluxation. And if you look at these two images, you can see that the transverse axis of the atlas has rotated about the transverse axis of the axis. And by definition, as Professor Pang defined it, rotatory subluxation is when the axis is fixed and the atlas rotates about the axis. So why do we need to do all these images? We need to do these images because we have to understand the radiological anatomy to decide on how we are going to fix these joints and ensure there is no mobility. CT scan is also very useful in certain congenital conditions like this one, which we have talked a lot about and written about, the so-called Proatlas Segmentation anomaly. Here's a child with torticollis. You see what's happening here. That's the occipital condyle, which is hypoplastic on one side. There is no lateral mass of C1. There's fresh air, and then there's lateral mass of C2. Here is the lateral mass of C1 on the other side, a normal occipital condyle, a normal lateral mass of C2, which means that this lateral part of the embryological proatlas has not developed. And this is best appreciated on a CT scan. Okay, that's the anatomy. What are the types of subluxations? Of course, the standard subluxation that we talk about is the front to back linear subluxation, which means that as this C1 moves forward, the posterior arch of C1 hits the spinal cord. The SAC, the space available for the cord, is reduced. And of course, we know the famous Steele's rule of third, which means at C1, C2, 1/3 of the space should be occupied by the cord and 1/3 by the odontoid, and 1/3 space should be fresh air available to protect the cord. So, you know, the anterior arch of C1, often in children, can override on extension, and this is something that you need to be aware of when you're dealing with children. Let's look at some patients. Here's a 16-year-old involved in a motorcycle accident. Fracture of the odontoid process, subluxation of C1 on C2. It can be reduced by putting him on traction, and you can see there is definitely a subluxation on these flex X images. And of course, because it can be reduced on traction, the treatment is to get some screws posteriorly, put them through the joint, the so-called C1, C2 transarticular screw. And this is combined with a bone graft and a sublaminar galley type of fusion. So we put in a C1, C2 transarticular screw, supplement it with some other type of posterior fusion, because this is not good enough to be standalone, particularly in children. And if we can reduce that C1, C2, we just fix it from the back. So if the subluxation is an anterior transverse subluxation, which is reducible either on moving the neck, so reducible on extension, or reducible on traction, principle of surgery, fix them from the back. But if you have a child like this with a horrendous subluxation like this, and where the subluxation is not reducible either on traction or on extension, and you have an abnormal odontoid process significantly compressing that spinal cord there, the treatment of choice historically was to go transorally through the mouth with that, the crocard transoral retractor, get in and drill off that odontoid process. So convert an image like this into an image like this. See, you immediately decompress that C1, C2, you change that angulation, you make that craniocervical junction breathe easily as you take off that odontoid process. And of course, every time you take that off, you do a posterior fixation, and that's what the CT looks like post-op. So this was the standard approach to patients where there was no reduction either on movement of the neck or on traction. Treatment was transoral decompression and posterior fixation. So this was the first type of linear atlantoaxial subluxation we knew about. The atlas moved forwards, its posterior arch went and hit the cord, producing the neurological deficit. Okay. And this is what was happening. The ADI was becoming less as this moved was becoming more as this anterior arch moved forward. And if it moved forward like this, that's 5 millimeter, that's pathological because the posterior arch would then compress the cord. Okay, but sometimes you see these children. This is a little girl who turns up in my clinic with severe painful torticollis. And of course, you know, looking at her and definitely looking at her CT scans, and I've shown you this before, this is a C1, C2 rotatory subluxation. Looks horrendous, very easy to treat. Put them on a normal Holter traction, not even skeletal traction, Philadelphia collar, and they can all go home in 48 to 72 hours, and less than 5% need surgical intervention. So far we have two types of ADs. We have the linear AD, which is front to back, and we have the rotational AD, which means C1 is rotating about a fixed C2. And indeed, this is the definition of rotatory atlantoaxial subluxation as defined by Fielding and later by Dackling-Pang. The subaxial spine and C2 are fixed and C1 is rotating. And we'll come back to that later. But at this moment, we now know that there are two types of atlantoaxial subluxations, a front to back linear and a rotatory type. And long before human beings knew about them, there were some creatures that knew that these subluxations exist. And some creatures like this Himalayan python I photographed in my travels in the mountains some 7, 8 years ago, swallows its prey by grasping the prey by the neck, producing an atlantoaxial subluxation which paralyzes its prey, and then it can devour the prey as a whole. Because most snakes do not like their breakfast to kick around in their esophagus when they're enjoying their breakfast. So they produce atlantoaxial subluxation before they swallow their prey. Right. However, everything changed. And everything changed because we understood that we did not pay any attention to the joint, the C1, C2 joint. We also did not pay attention to the fact that in addition to front and back movement and rotatory movement, there was a vertical upward movement of the odontoid itself. And this was a condition that was called basilar invagination. To my mind, it's just a vertical subluxation. And once we realized that, we realized there is no need to go in through the mouth and take off the odontoid process. You can now open the joint and simply pull that odontoid process down, much as you do to reduce a lumbar listhesis in the lumbar spine in adults. And of course, we could very easily expose this area. And I'm going to show you this is what we do now for these children. We do not do a transoral odontoidectomy in the majority. We expose the joint. That's the dorsal root ganglion of C2. That's the vertebral artery here pulsating. That's the lateral margin of the spinal cord. Here's the joint. So we're going to expose that C1, C2 joint. We're going to put in a lateral mass screw after we've drilled this off into C1. We're going to put in a pedicle screw into C2. And then by distracting this, we pull that odontoid process down. And as we pull that odontoid process down, we can now reduce the subluxation without having to go anteriorly and do a transoral odontoidectomy. So that's the joint opening. That's the lateral mass screw into C1. These are the pedicle screws into C2. And wow, we've managed to reduce that odontoid process, bring it down from the back without opening the mouth. And here you are, complete decompression, all available from the back, a process that Professor Goel and Professor Harms first showed us. And this is what we now do for most of these children. Look at that space available for the cord. You don't have to take that odontoid off. You simply open the joint, pull that whole thing down. Now you look at the space available for the cord and you simply fix them from the back. And this was the so-called posterior approach. And we thought everybody can be done through the posterior approach. Even patients like this, look at, this is the child with another lateral proatlas failure, which I described earlier. You see, that's the occipital condyle. That's the lateral mass of C1. That's the lateral mass of C2. There is no lateral mass of C1 on this side. So this child comes to us with a torticollis and spastic quadriparesis. And of course, you have to reduce this child. Now, how do we do that? The posterior arch of C1 is stuck to the foramen magnum, and yet we need to bring that C2 down to reduce the basilar invagination. So this is what we do, and this is just to show you how you constantly improvise when you operate on children in this region. We create a new foramen magnum. So we drill off to create a new foramen magnum. That's the foramen magnum we've created. We put a hook into the margin of that foramen magnum. We put a pedicle screw into C2, and then we distract this C2 from the margin of the foramen magnum we've created. So you see, as we distract, like so, slowly, and possibly under neuromonitoring if we can, so you see amount of distraction, we can bring down that C2 very effectively. So you end up with a process like this. That's your screw into the margin of the new foramen magnum you've created. That's your pedicle screw into C2. You distracted and brought that odontoid process, which was inside, down. So with a posterior approach, you've now been able to reduce this basilar invagination and make it a normal level. What about a child like this? You can see the compression from the back, and you can see the significant squashing of that spinal cord. Again, here's a process. You don't need to do a transoral odontoidectomy. You can open the joint from the back, bring that down, and look at that post-operative image. You've got a graft in here. You've got your lateral mass screw into C1, pedicle screw into C2. You've got the decompression, and you brought that odontoid process down. And this is what we do for majority of these children. Here's a preoperative image, basilar invagination, joint open, brought down. Here's a C0 to C2 fixation, but we brought that odontoid down without anterior surgery. So now we have 3 types of subluxation. In addition to the front and back and the rotation, we have a vertical upwards subluxation, and we choose to call it basilar invagination. You can call it platybasia, but fundamentally what we're saying is this is what is happening. The odontoid is traveling vertically upwards. And here's the summary so far. We have 3 types of atlantoaxial subluxation. Front to back linear, rotatory, C1 rotating on C2, and the vertical upward movement of C2 through the arch of C1 through the foramen magnum, condition we call basilar invagination. And the truth is that in every craniovertebral anomaly, these 3 subluxations exist together. Too much of serious talk. Here are 4 young men. Some of the people in the audience who are closer to my age might recognize them. Yes, indeed, they are the Beatles. And they sang a song which I particularly like. Yesterday, all my troubles seemed so far away. Now it looks as though they're here to stay. Oh, I believe in yesterday. Why do I say this? We thought every child can be operated from the back. Here's a young man, 13 years old. Look at his spastic quadriparesis, but more importantly, look at that odontoid process. Severely, retroflexed, resting on that spinal cord. Would you do this? Again, opening the joint and pulling that down. Would you be able to risk pulling this odontoid process, indeed C2 down, by opening the joint? Is the answer. It is our humble contention that if you have a severely lordotic tilt with a odontoid process, which is hugely retroflexed. And this is a photograph I borrowed from Professor Dakling Peng. This is an anterior platybasia with a hugely retroflexed odontoid. If you try and open the joint and pull this down, there is a risk you might pull it down along the yellow line and cause severe disruption at the craniovertebral junction. So this is a posterior platybasia without a retroflexed odontoid. You can open the joint and bring that down. But with a severely retroflexed odontoid, you have to do the age-old surgery, which is to go in and do a transoral odontoidectomy. Otherwise, you'll not have that cord looking like this. And if you try to pull this down, there is a risk that this odontoid process might come and hit this cord. And in fact, we know there's been lots of reports of sudden death after posterior surgery in children with C1, C2 subluxations and retroflexed odontoid for precisely this reason. Okay, when we looked at our first 100 pediatric craniovertebral anomalies, this is what we found. 42 of them were due to malformations of the occiput, atlas, and axis, and 24 of them were due to trauma. This was the trauma in our pediatric age group that produced C1, C2 subluxations. Infection in our part of the world, the commonest, of course, was tuberculosis, very rarely pyogenic, and of course the Grisel syndrome, to which I've alluded earlier. And finally, TB, which I'll come back to, where often we do a transoral aspiration of that cold abscess. You see this big cold abscess, these children have severe neck pain, and you can do a transoral aspiration, obviously under anesthesia, take out this cold abscess, gives you a diagnosis and relieves the pain, and torticollis before you do anything else. And some of them, of course, of our children are syndromic, the two common ones being Down syndrome and Morquio. So this is what we know so far. Our attitude to problems in this region is to first ask, is there a subluxation? If there is one, is it linear or rotatory? Is it reducible or irreducible? And what's the cause? Okay. But sometimes you have children that really, really confound you. Here is a child who came with torticollis. You can see if you look at the flexion extension images, it doesn't look that he's got a great subluxation. But look at this. He's got a Chiari malformation. He's got a big syrinx. And then if you look at his bone, he's got a lateral proatlas failure. Look, big lateral mass here, very small lateral mass here. There's that tilt. And he's also got a rotatory component with a rotation of C1 on C2. 3 pathologies for the price of 1. And of course, this is not easy to operate on. I'm just going to show you a very, very quick video just to show you the problems we have when we operate on these children. All of these are done under intraoperative neuromonitoring. Here's the first problem we found. You don't get a satisfactory baseline in these children who come with spastic quadriparesis. And you don't get it because if you use a train of 4 stimulus with these metal tongs giving traction, then it doesn't work. So instead of a train of 4, you need a train of 8. This is what we normally do. You may appreciate, we take a triangular flap of muscle here. I don't cut the muscle linearly. We take a big triangular flap and leave it up, so that if there is a CSF leak, this triangular flap sits very nicely. And there's the drill, there's the pedicle screw of C2, that's the lateral mass screws of C3. And now we're going to deal with the Chiari. We're going to take off the posterior arch of C1 and also the open up the foramen magnum. But because this child is horrendously unstable, we have to first fix the craniovertebral junction. And this is what I like. I like a system where you can put in a pedicle screw into C2, a lateral mass screw into C1, and then just put one separate occipital plate, one on each side. It allows you to position the occipital plate where you like. So the position of the occipital plate is in your hands. You can move it lateral or medial, and then you do the same on this side. And then you finally do the decompression. And I won't take you through the rest of this video in the interest of time. but that's what it looks like post-operatively. You have to do a fixation in the occiput because remember, you've taken off the posterior arch of C1 and opened up the foramen magnum in this child. And that's what the child's CT looks like post-operatively. Okay, so we have a lot of information. How about an algorithm to make us tell you, how do I approach children with craniovertebral anomalies? How do we deal with them? So this is the algorithm. First question, is there an AAD? I told you, we decide on flexion extension, X-rays and CTs. Question 2, is it reducible? Reducible mostly either in position, so reducible on extension of the neck or reducible on traction. And I just put this photograph in to show you that when we put these children, this is a child who's got spastic quadriparesis in traction. We don't like to keep them confined to bed. So if they're quadriparetic, we put them on a wheelchair, put up that frame and allow that traction to stay and they can roam around the wards. If they're ambulant, we give them a walking frame. They still have that traction and they can walk around the wards. It's cruel to have a child lying in bed on traction for 72 hours. It's very, very unfair on the child and even more on his parents. So we say, is there an AAD based on this? And the answer is either no or yes. If the answer is yes, we say, is it reducible? Is it reducible on traction? Is it reducible on movement? Or is it irreducible? Okay, if it's reducible, we ask, is there compression? If there is compression, is it anterior and posterior compression? Or is it only posterior compression? If it's reducible, either with anterior and posterior or with posterior, you only need to decompress from the back and you fix from the back. If there is no compression but instability, you don't need to decompress, simply fix from the back. That's what we do with reducible atlantoaxial subluxations. If it's not reducible on position and on traction, we ask ourselves, is there a retroverted odontoid? Is there platybasia? Is there an abnormal bone which will stop me reducing this odontoid which has moved up from the back? If the answer is yes, they need a transoral odontoidectomy and fixation. If the answer is no, there is no retroverted odontoid, like I showed you, no abnormal bone preventing, then we ask, is there basilar invagination? Yes or no. If there's basilar invagination, you open the joint, you decompress, you give traction, and you reduce in the way I showed you. If there is no basilar invagination, you just open the joint and fix them from the back. You don't need to do decompress. You do not need to put traction, distract them, and reduce that basilar invagination. Okay, so here's a very quick summary of how we deal with craniovertebral anomalies and atlantoaxial subluxations by saying yes or no. And if it's not reducible, as I said, and I just repeat myself so that you can get an idea. It's very clear. It's all very clear. Mathematics, 2 + 2 = 4. Now, you know, the first day that we have students in our department, I always tell them that neurosurgical education has begun in your life and it involves answering questions. But neurosurgical education only progresses when you can question answers. So it's not enough to answer questions, but you need to question answers. And this is an example of questioning answers. We know that Professor Goel wrote, anterior surgery for AD is obsolete. There is no place for transoral surgery anymore. I've just shown you, if you have a severely retroflexed odontoid, then that needs anterior surgery even today. Professor Pang, from whom we've learned so much about problems in this region, this is quotation from his article. All rotational AD involves an atlas, which is rotating around a fixed axis. Remember, atlas rotating around a fixed axis. Look at this child of mine. Spastic quadriparesis with a hemiparesis on one side more than the other. It's a condition called C1 hypocaudal bow-aplasia, and there is agenesis of the anterior arch of C1. Look at the CT scans. Look at this scan, C1, which is fixed to the occiput and in its transverse axis. Look at this scan, C2. Hang on a second. C2 looks to have rotated, not C1. And if you look at the recons, that's a lateral proatlas failure. That's the tilt of C1. See that C1 is fixed in its transverse axis. It is C2 that rotates. And because C2 rotates, sorry, I just put my timer on 50 minutes. So because C2 rotates, it corrects the lateral tilt. And here's the condition, therefore, that there is rotation of C2 on a fixed C1, which is completely different from the way Professor Pang defined it. So this is what we define as a reversed rotatory subluxation in these children with lateral proatlas failure. C1 is fixed, C2 rotates with the subaxial cervical spine. And of course, as I said, you have to question answers. Sometimes you have children like this. This is a small child, 13 months old with a fixed torticollis. Look at that C1, C2. You can drive an SUV through that space between the odontoid and the anterior arch of C1. Flexion extension films show huge subluxation. Look at the CT. Oh my goodness, what's going on? There's an abnormal bit of bone going right through the foramen magnum. And if you look at the recons, there's that piece of bone going from the posterior part of C2 right through the foramen magnum. And if you look at the intracranial part, it's going and getting attached to the clivus. A craniovertebral anomaly with a piece of bone going from C2 through the foramen magnum and hitting the clivus with a very abnormal clivus. And of course, this is a very unique condition. We call this a failure of the hypocaudal bar. It's an embryological term that I have to confess I have coined myself for want of anything else. And what happens in these children is that the hypocaudal bar has no place to articulate it with because there is a lateral proatlas failure. So it goes and attaches itself to the clivus, the only piece of bone it can find. And operating on these children, I can tell you, is a nightmare. That's what we ended up doing. A contoured rod, 13 months old, you have no implements that you can use. This is a sort of temporary method of doing a fixation. And of course, these children will need, this would lasted for all of 2.5 years. And then the child was bigger and we could do a formal C1, C2 transarticular fixation. I'm just going to show you a little video of an operation. As I told you, we have to question answers. Here is a child who comes with an AD and a hangman's fracture. I see this child when the child is 3 months old. Those are the images. And I say, my goodness, we can do nothing at this age. Let's wait. Child comes back. He's 6 months old. He's got a lateral proatlas failure, C1, C2, subluxation. He also has an atlantoaxial subluxation and a hangman's fracture. He's now getting increasingly paraparetic. He's 7 months old, and we have to do something to reduce the C1, C2, and the hangman's fracture. Look at that FlexX film. Look at that. What do we do? So here's the operation. This child is 7 months old. Of course, this is done under neuromonitoring. I'm not going to go into that. But just to very quickly show you the travails of a pediatric neurosurgeon having to operate in this region and the fact that you have to improvise at all stages. After we exposed, we thought the only way we could do this is to get a sublaminar wire, put that under C3, pass that under C2, and then pass that under C1, so that in one shot, from C3, which is here, to C1 here, look how it moves because it's all cartilaginous. We can get a wire to go through C3, pass below C2 and go out above C1 so that we can get both the C1, C2 and the C2, C3 subluxations to reduce. And that's how difficult it can be to put a sublaminar wire in a 7-month-old. And I share this video with you because you'll appreciate or enjoy, or might even get sadistic pleasure looking at how difficult it is to try and put this in. That's C3, that's C2, that's C1. I'm trying to get that. This is in fact a wire, titanium wire, which I'm trying to get underneath all of these, so that once I've got it in on both sides, I am going to now try and reduce both the C1, C2 subluxation and the hangman's fracture in one shot. Not very easy. This is doing it on the other side. These are the cables. So these are very nice. And then of course, we also need to do a little bit of exposure here of C1. So that was going through C2 and C3. Now we're exposing the posterior arch of C1. We're now going to get this wire, which we've put in with difficulty, sublaminar C2 and C3, to go sublaminar through C1, so that we can get a complete reduction. So that same wire, the top of it now goes through sublaminar of C1. And you can appreciate how little space you have. That's the foramen magnum, so that you don't want it to go and hit the brainstem there. So we use these micro hooks to try and lift that up. And then once we've lifted that up, and again, this is quite a struggle to lift it up, even in this edited video. And you see it gradually comes. You talk to it nicely, and it ultimately comes. And you've got it, wow, through sublaminar C3, C2, C1. Remember, these are cartilaginous lamina. You can't use too much force. If you use too much force, it is going to break through all those lamina, and the wire will come out in your hand. And it's not what you ideally want. So once we've done this, then we gradually tighten these cables. And of course, there is a nice graded way of tightening these cables, as you know. So you know how much pressure you're exerting as you tighten them. I'm just showing you this video because this is just to show you how complex surgery can get, but really how simple it. That's the bit of bone graft then we put in, so that we get a bit of bone graft. I normally use ribs in small children. This is in fact ilia crest, but normally I use, and that's what it looks like. You see, you can reduce all of them in that one shot by doing that. And I'll spare you the agony of the rest of this. Here's another child, just to give you an example before I close of some of the amazing ways these children present. Here's a child presenting with a hypoglossal nerve palsy. And when we investigate it, you see there's infection. This is tuberculosis of the C0, C1 joint. And we were able to do a transoral aspiration of that cold abscess. Here's a 15-year-old girl with torticollis. Again, I showed you this girl. There's the cold abscess. We put them under anesthesia, put in the Clowards retractor, put in the Crocard's retractor, do aspiration of that cold abscess, and cure their pain and torticollis. In fact, we wrote up about our experience of craniovertebral tuberculosis in children some years ago, where we classified these children into 3 categories, and I won't go into the details of that. Sometimes you have these children that come with this so-called Proatlas segmentation anomaly. Fixation can be quite difficult, but I'm showing you this because this is ribs. This is what I like to use in occipito-cervical fusion in children. And here it is, the pre-op picture and the post-op. You open the joint, fix them from the back. And sometimes you have these children, like this child who came to me with torticollis. That's the CT scan. There is no cervical spine. You have, that's the T1 vertebra, that's the occiput. That's the whole of the cervical spine. And of course, with these children, it's quite a challenge to do anything at all. Remember, I said education begins by answering questions. Education progresses when you question answers. I always say, education reaches its final stage when you question the questions themselves. And I hope some of the cases I've just shown you gives you an opportunity to question the questions themselves. Once you can do so, you can all venture out into the tiger country we call the craniovertebral junction. It is exactly 1 hour, so thank you very much for your attention. If you're still awake, thank you.
Thank you. Thank you so much. Very nice presentation. Excellent. Excellent. So, Sandip, just a little question before to open for the other panelists. Just about Morquio syndrome. What is your management of this very difficult patient?
So with Morquio, we do not ever do a C1, C2 fixation. With all Morquio kids, these are children that we actually put in a halo, and I operate keeping them in the halo, just taking the back off. And we always do a C0, C2, C3, C4 fixation. I do a long segment in Morquios. I have learned the hard way that if you try and do C1, C2, you invariably end up revising it and doing a C0, C2, C3 fixation. So with the Morquio kids, we would do a C0, C2, C3, C4, bring down the level of fixation right down to C4, because I think that's the only way you get sufficient stability. I'd never do that in other children, because if you just have a C1, C2 subluxation, it doesn't make any sense to include the occiput in your fixation if you can avoid it. The two exceptions that I make, number one is with Morquios, and number two is with Down syndrome children. Because again, Down syndrome, remember, their problem is laxity of ligaments, like Morquios. And the laxity of the ligaments is not the ligaments only of the C1, C2 joint, it's also of the C0, C1 joint. So you have to fix C0.
Barbara, would you say something?
Just learning here. You know, we are listening Professor Goel, Atul Goel, a good friend of us, during all the meetings. He never talked about this posterior dislocation of the odontoid. If in this situation you need the anterior approach, the transoral approach, or transnasal, either one. Why you conclude this against his theory about that?
Yeah, I'll tell you why. If you look at certain publications, and I refer to two publications that you can read up. One was published last year in April in World Neurosurgery from Seoul. I actually reviewed the paper. They report on 4 patients with atlantoaxial subluxation who underwent a Goel procedure. 2 never woke up, ended up on ventilators, and actually did not survive. And 2 that woke up, went from the operating room to the intensive care, and suddenly became quadriplegic. And in one of them, they re-explored and did an anterior decompression, and the child, it wasn't a child, it was a teenager, it was a 19-year-old who improved. And in fact, there is a case even at the All India Institute of Medical Science in New Delhi, where there's been a death after this Goel procedure. And when we've gone and looked at all these images, and particularly in this article in World Neurosurgery, which, as I said, I reviewed them, so I had access to the raw data, all of these had severely retroflexed odontoids. That was what was in common. And I've had a patient, I've had a child of 11 years with a severely retroflexed odontoid, where I've opened the joint, distracted it in the way I just showed you, and the child deteriorated post-operatively. In fact, the neurology became grade 0, the child ended up on a ventilator, and when we did the imaging post-operatively, we found there was a signal change in the brainstem, which almost certainly I thought to my mind meant when I reduced it, I had inadvertently dragged that tip of that odontoid to cause pressure on the brainstem. Fortunately, this child recovered, but it was this experience and looking at these sort of problems that we certainly in my practice, if we have a severely retroflexed odontoid, I will not try and reduce it by opening the joint. Remember when you open the joint and you reduce it, the trajectory in which you're reducing it is the trajectory between the lateral mass of C1 and the pedicle screw into C2. You can't push it forward. So you're really bringing it down vertically. But if you have to bring it down vertically and to change its orientation, so you want to change it from like this into this, that's not easily possible with this screw. And we've had a lot of discussions with Atul, who's an extremely close friend of mine. And I have to say that in most meetings that we talk about in India, children particularly, we agree to disagree on this matter. Of course, Atul has no complications, so we don't know about his complications.
It's impossible to disagree from him. He's always right. And the other question is the pedicle of C2 in children is very small sometimes. And there is the malformation also of the bone. If you don't have this pedicle screw, the right side, and what will be the other option to do this kind of surgery? If the pedicle is still not good enough.
Yeah, I mean,
and the vertebral artery, how you manage also?
Yeah, so pedicle screw of C2, first of all, if most of these children, we do not use what is actually sold in the market as a cervical pedicle screw. We use small lateral mass screws as pedicle screws because we don't get the right size in children. In fact, you might be shocked.
3.5.
That's correct. Very, very small ones. But, you know, we've even used something called a lateral malleolar screw, which orthopedic surgeons use to fix lateral malleolar fractures in children, which I saw when I was at the Sick Kids in Toronto. And the chief of pediatric orthopedics there was a man called Professor Salter, who actually described the fractures around the ankle. And he used to use these screws that he had devised to fix the lateral malleolus. They are cannulated screws. So we have been using these screws. We tell the parents this is an off-label use because we don't have a screw of that size. I've used these cannulated lateral mass screws as trans-articular C1, C2 screws in children which are 5 years old, where you cannot put in the standard commercially available trans-articular screws. So you're improvising with your instruments all the time. If you think the pedicle is malformed, then quite oftentimes we'd settle for a PAR screw. And even if you can get a PAR screw, then the worst scenario, I don't like it because it's not very stable, and in children, it's not very stable at all, is the option of putting in a laminar screw as well. So you have these three options, and of course, if you break the pedicle, then it's a rescue screw. You can put a PARS or a laminar screw into C2. But the trick of avoiding the vertebral artery is to remember that the pedicle screw must be directed not only superiorly, but definitely medially from where you get in. Our technique is that I use a small dissector to mark the lateral extent of the spinal canal. So I trace the upper border of C2 where it curves inwards. That's the lateral border of your spinal canal. I get my assistant to keep that dissector there, which marks the lateral border of the spinal canal. And I angulate my pedicle screw. I angulate my drill when I'm drilling before the pedicle screw in such a way that I go as far medially as I can without transgressing where he's got his dissector, because that's the lateral margin of the spinal canal. That way you stay well away from the vertebral artery.
Thank you, sir.
On the vertebral, oh, sorry.
No. Please see. Go ahead.
Oh, congratulations, Sandip. It's a great privilege, like always. He is the chairman of the education committee. I'm the vice chair. And two questions on your excellent presentation. You are talking about the vertebral artery. Did you have some injury in the vertebral artery, and what was your strategy to solve the problem? And the second is about monitoring. When you use before putting the position, or you put the child in the surgical position and you go to monitoring afterwards?
So I'll take your second question first, Nelsie. We monitor children right from the time they're anesthetized. So remember that after they come into the operating theater, the anesthetists, before they put in the endotracheal tube, if it's a big child and the child is able to understand what you want to do, we would put the traction under local anesthesia before they intubate. If it's a small child, you can't do that. Then they use fiber optic intubation, and then we put in the traction to try and reduce. Now, we get baseline intraoperative neuromonitoring, which is SSEPs, MEPs, free-running EMGs on these children before we put traction, after we put traction in the supine position. Then we turn them prone and get another set of baseline. And sometimes, just by turning them prone and repositioning them, you'll find that your SSEPs latencies are going up or your amplitudes are going down. Then you have to reposition them. See, the positioning has to be a compromise between what you're seeing on the intraoperative neuromonitoring and what is a comfortable position for the surgeons. To give you an example, the most comfortable position for surgeons to operate in this region is if you can get these children's necks completely flexed. But if you try and flex them too much, you actually cause them to subluxate, and you find that your MEPs, amplitudes going down. So you have to choose a position which is not too much a flexion, but at the same time, if you have too much extension, then surgically getting to this region becomes much more a challenge. So because you need a compromise, that's why the monitoring helps, and it tells you what's the safe position to put your child in. Question number one, have I caused a vertebral artery injury? Unashamedly, yes, I have. I don't think anybody who's operated on this region would have said that we've never caused it. Just for your information, Atul goes around the world saying he has damaged 75 vertebral arteries in his life, and nothing has happened to any of them. He's done nothing to repair them, simply put compression and come away, and they've all done fine. I have definitely caused 3 vertebral artery injuries. The principle is, of course, when you cause an injury is to, if you do it while putting in a screw, and you understand that very well, of course, because you have a gush of blood coming out through the tract after you take out your drill or your tap, then of course the first thing you do is put in the screw immediately to stop the bleeding and tamponade at it. Then you do the other side very, very carefully if you have to do it, or sometimes you may not even do the other side. And then we routinely would do a vertebral angiogram on these children when they wake up. So 48 hours, 24 hours later, we would do a vertebral angiogram. We have actually never found in any of these 3 cases we've done an angiogram then a pseudoaneurysm or a need to go back or any form of perfusion problems. But maybe we've been lucky. But Atul is even luckier because he says he's done it to 75 people and had no problems. So perhaps the vertebral artery injury is not as terrible a thing as we make it out to be.
Ricardo, would you say something?
Yes. Congratulations, Professor Sandip. It was an amazing lecture. So if we wonder that in Brazil we have a difficult case, you show us more difficult case than usually we see here. So it's an amazing experience. So I'd like to ask you about some different topics. So the first is, what do you do with the ozodontoidium in your practice? All your ozodontoidium patients you indicate surgery, or do you have any special algorithm to decide when to do the surgery or not?
Okay, so you remember in my algorithm I said, if you look at the atlantoaxial, first of all, we would operate on ozodontoidium if they were symptomatic. I would not operate on ozodontoidium because it is there in a child who has no symptoms at all. So we would operate if they were symptomatic. If you remember in my algorithm, I said, that we would reduce it from the back in situations where there was not either a retroflexed odontoid or an abnormal piece of bone that would stop my being able to reduce it by opening the joint from the back. And in an os-odontoideum, generally, you can still reduce them from the back, majority of the times, as opposed to an os avis or a third ossicle. Often, if you have this ossicle, then that comes between the anterior arch of C1 and the odontoid process and stops you from getting a reduction from the back. But with the os-odontoideum, majority of the times, you can get a reduction by opening the joint from the back. And you really don't need to go in and do a transoral odontectomy. If it's an abnormal bone, like, as I said, an os avis or an abnormal ossicle, then I would do a transoral odontoidectomy and then fix from the back, rather than open the joint and reduce from the back. So that abnormal bone in the algorithm is what is the critical point.
Interesting. In MPS patients, especially in type 6 MPS patients, do you always open the dura to decompress because there is a kind of penus in the dura mater, or only you decompress without open the dura? And you use any kind of device to stabilization, or do you think only the decompression is enough in type 6 MPS patients?
I am aware of the school that says you have to open the dura. Personally, I have to say I do not open the dura. I find it a challenge enough to operate on these children. And if you put all these fixation devices and you get a CSF leak, then God forbid, I think that's just terrible to manage. So I generally do not open the dura. I haven't opened the dura, though I'm aware of the literature about it. And of course, we would do a fixation. I would never do a decompression and not fix these children. I would definitely fix them if I decompress them.
Okay.
Because of the same reason that I said before. The problem, remember, is of ligamentous laxity. So even if they don't have documented instability, once you decompress them, you're providing them with an iatrogenic instability.
And the last question, I think. And a very common situation, the Down syndrome. How do you deal about the miseries and how to avoid the activities when you decide to operate in patients asymptomatic but the large ADE distance?
Yeah, I think this is a problem we have yet to solve in the pediatric neurosurgical community. Everybody has a different take on this.
Yes.
As far as I am concerned, I will be honest with you. If I see a Down syndrome kid with a C1, C2 subluxation who is completely asymptomatic, I just tell the parents that they need to be aware that the child has this condition and that contact sports should be avoided. So they shouldn't do sort of, high diving or rugby or boxing. But I generally do not tell them that they should not indulge in sporting activities at all, because I think that's a torture for these children. So I just tell them to avoid contact sports, and I only operate on them when they're symptomatic, never prophylactic.
Thank you.
Sandip, we have some questions for the audience. The first is the Brahim Kamoun. The question is if the algorithm that you showed for us is also applicable to adults.
Yes, with some minor modifications. Yes, it is applicable to adults. With adults, you don't have these issues of a severely retroflexed odontoid most of the time. And in adults, we don't deal with these congenital pieces of bones that we just talked about. But otherwise, yes, I follow the same algorithm even for adults.
The same Brahim is C1, C2 fixation should be done in neutral position. How can you access that perioperatively?
No, it doesn't. You don't do it in a neutral position. You do it in a position in which you reduce the subluxation. And that most oftentimes is in slight to moderate extension. So you have to put the neck in a position of slight extension to be able to reduce it in most cases. And that's why I said how much extension that you use is determined by the intraoperative neuromonitoring. But it is never neutral. It is almost always in slight extension that you can get the reduction, because you want that position to be in a reduced C1, C2 position, and then you want to fix the joint. So you want the neck to be slightly extended. Most of the time, if you flex, they get more subluxed, and if you extend, they get less subluxed.
And concerning the C1, C2 fixation by Professor Goel recommended for adults is the same. Do you think that there are some particularities from children in comparison for adult patient in this kind of surgery, in this kind of approach?
Well, if you know, Professor Goel does exactly what I showed you, which is open the joint, lateral mass screw into C1, pedicle screw into C2. But he has a cage which he puts into the C1, C2 joint. Now, for children, it is impossible to get that cage. I've tried to put that cage in. It invariably slips. Remember that these joints are an abnormal angle. So these cages slip out. So in children, I think you can do the Goel procedure. As far as I'm concerned, I never put in the cage. Instead, I pack the joint with bone chips or bone graft, and then I put in the screws into C1 and C2. Interestingly enough, some years ago, I was having a conversation with Atul, and I said to him, Atul, I have never managed to put in your cage in children. And he turned around and said to me, neither have I. So in children, I think the cages don't work, but otherwise the same operation.
Professor Sandip, in the same way, I'd like your comment about the theory from Atul Goel about the Chiari malformation is caused by the C1, C2 problem, and all the patients have to be treated by C1, C2 fixation, not the posterior fossa. What do you think about this theory?
I would invite you to read my article published in the annual issue of Child's Nervous System last year, where I have actually said that what Atul is saying and what people like Arnold Menezes told us many years ago, and what a lot of other people are saying is probably the same thing. But some people like Atul Goel are very dogmatic in what they say, and other people are less so. So, you know, this business of fixing the C1, C2 joint for syrinxes. First of all, if you ask me, do I do it? The answer is unequivocally no. I would fix a C1, C2 joint with the Chiari. I showed you a case. If there is a demonstrated C1, C2 subluxation with the Chiari. Certainly, I would recommend every child that is a Chiari should have a dynamic X-ray or a dynamic CT to be absolutely certain they are unstable before you do the Chiari. Because if you decompress them and you don't fix them and they have instability, then they will deteriorate neurologically. So there is no question about that. But I would not fix a child who's got a Chiari without decompressing, simply fix C1, C2 in the absence of demonstrated instability, which is what Professor Goel's article is all about. And I think the reason why everybody says this, and I've written this, if you see, I've actually written in this article that I wrote saying that ultimately, if you analyze what everybody is saying, it is an attempt to stop compression. It is to decompress. What people who just do posterior decompression are doing is decompressing from the back. What people like Atul who try and fix it are doing is, remember, they are extending the neck when they're fixing. And the moment you extend the neck, you open up that space. So they are also decompressing in another way. They are decompressing by changing the position of the neck when they're doing their fixation. So ultimately, probably everybody is doing the same thing. They're decompressing, some by removing bone, some by changing the position and fixing it in extension.
Okay, Griselda from Mexico, would you add something?
Congratulations, Professor, for excellent lecture. I want to ask whether you recommend in babies less 5 months old with also odontoideal and craniovertebral instability because they have cartilaginous plates and it's difficult related to management. how can we treat these patients?
So I showed you two examples of children that were 1 year or below that I had to operate on. First of all, I showed you this child with C1, C2 and a hangman's. And if you see, we just improvised and put in a sublaminar wire through all of these. These children, that very small babies, 1 year old, 18 months old, 2 years old, you have to decide on fixation depending on the pathology. I think we just create a method of doing it. You can't work on an algorithm. I showed you another small child, if you remember, with the torticollis on lateral proatlas failure. We used a small contoured rod, which we actually make in our own hospital from titanium, and we bend it to make it to that shape. And then we make 2 holes in the occiput, put sublaminar wire, fix it to the occiput bit, and sublaminar we fix C1 and C2 to the rods of that contoured rod. That's the only thing you can use in a child who's 18 months old, because no equipment, no standard instruments can be used. There's no transarticular screw, there's no C1 lateral mass screw, there's no pedicle screw of that size that you can use. When they're a bit older, as I told you, you can use a variety of other screws that are cannulated, one being this lateral malleolar screw that I talked about, because it goes over a K wire. So you can put in a K wire and then thread the screw over it. They're very small, and therefore it works in children. So what equipment you use, I always tell the parents at this age, there is no way in which I can fix your child permanently. This is a temporary solution till the child is a little older, maybe 3, 4, 5 years old, and this fixation system will disintegrate, and majority of them do, and we will have to do revisional surgery. So it's like, that child that I showed you, I've operated on this child 6 months ago with the hangman's and C1, C2. I'm absolutely certain in another year or two, that child's going to come back with those sublaminar wires all snapped. But by then, the child will be big enough for me to try another method of fixation. So really, I don't have an answer. What is the ideal way to fix a small baby? I think you have to work it out as you go along.
Thank you.
Professor Salomon, Milton, would you say something?
Yeah, Sandip, just a small question. Kids with occipitocondyle hypoplasia and a child with the torticollis, is that condition unstable? I mean, there is some kind of rotational subluxation?
Yes, there always is a subluxation because, you see, because the lateral part of the proatlas doesn't develop, these children are born without a transverse ligament of the atlas as well. So they're all unstable.
So the transverse ligament is involved in this pathology?
Absolutely, absolutely.
Okay. Okay. That's why it's unstable.
Yeah.
Thank you.
And just since you raised the issue, that's why we are trying to talk about this so-called reverse rotatory subluxation, where you have this lateral proatlas and C2 rotates rather than C1. Because, if you get torticollis because of a rotational subluxation, and it's the classical rotational subluxation where C1 is rotating about a fixed C2, 95% of these children will be reduced by traction, put them on a Philadelphia collar and send them home. But if you have a lateral proatlas failure producing torticollis, and you have this, what we have described as a reverse rotatory subluxation with C2 rotating about a fixed C1, 90% of them require surgical intervention. So for torticollis caused by rotation of C1, C2, in one type, 90% are treated conservatively. In the other type, 90% need surgical intervention. And this is why I think we need to highlight that there are two different types. There are two different animals, and they have to be treated separately.
Thank you.
Okay. Alexandre, would you say something?
Yes, thank you, Ricardo. Thank you, Dr. Sandip, for your magnificent lecture. And I have two questions indeed. And how frequent do you use bone grafting for posterior fixation, especially in infants? Is that an obligation to do that?
I think it's an obligation. I think if your aim is actually fusion, not fixation, and unless you got some bone there, you're not going to get fusion. So if I open up the joint, I would put bone graft into the joint. As I showed you, if I do a transarticular fixation, I get a big piece of bone, put it between the occiput and C1, and then even most of the times, I actually suture it with a wire. If it's a small child, I can use just a proline, but I would always use a bone graft, because without a bone graft, you're not going to get good fusion. And you really want that joint to become nice and fused. Just interestingly enough, my friend Doug Brockmeyer has been involved in a study where he gets these children after some years and wants to remove the implements. So he feels that after maybe a year and a half or 2 years, you don't need to keep these equipment because they would have fused. You can go in and remove all the metal work. And he convinced me to try and do some of these. And it was a nightmare, because when you go back after 18 months or 2 years, you can't find the metal work that you put in. It's all covered with bone. It's completely fused. And in fact, we gave up. I said, I'm not going to be part of this study because it seems rather strange to me that we've spent all this effort trying to get fusion. Now we drill off all the fusion to get off the bone and to get off the metal. So they fuse beautifully if you put in a bone graft. Whereas if you don't put in a bone graft, you'll have a fixation, but you'll not have a long-term fusion.
Okay, thank you. About Grisel syndrome, how far do you go trying to reduce it non-operatively with just giving some medicine to relax or put on a cervical orthosis, or do you operate on as soon as possible to fix it?
I think I have very rarely ever needed to operate on a Grisel syndrome. Majority of them are just treated by simple conservative treatment. You treat the infection, you immobilize the neck because they have a lot of pain. Very rarely you need to put them on traction, but majority of them do not require any surgical intervention. I do not think I've operated on a single patient with Grisel syndrome.
Oh yeah? Okay, thank you so much.
Salomão and Arthur, would you say something? Arthur?
Thank you very much, Sandip. Very nice presentation, but I have no question because all my questions are already answered. Thank you very much.
May I do a question?
Okay, Ricardo, please, go ahead.
It's a great opportunity to discuss. So, Sandip, I have 2 questions about complications. Probably the most difficult situations in these patients are airways and infections after the surgery. So in some patients, do you do a tracheostomy prophylactic to keep the airway stable after the surgery? Because the ICU doctors sometimes they're so afraid to how re-intubation these patients after surgery. It's not so easy, you know. Do you do tracheostomy prophylactic, and how you deal infections in your patients? You take out the device as soon as possible, or you try to keep the device to do antibiotics and open and wash? What you do in your infections case? So
with the issue of tracheostomy, when we started doing transoral odontoidectomies, this is about 25 years ago, we used to, in fact, do a tracheostomy on all the patients that we did a transoral odontoidectomy. Then we moved to the situation that we did transoral odontoidectomies and kept all the patients intubated postoperatively. In the last 15 years, we have never needed to do either a tracheostomy or keep a child that we're doing or an adult, we're doing a transoral odontoidectomy, intubated or have a tracheostomy. So things have improved and we rarely need a tracheostomy. Of course, what you say is absolutely correct. If this child has an airway problem in the intensive care, it is a nightmare for the intensivist or the anesthesiologist there to try and intubate the child. So we still have a protocol that if we do a craniovertebral surgery in a child with a difficult airway, fiber optic intubation is available next to the child's bed at all times for the first 48 hours. So that if there is a need, they can immediately get a scope in and then put in the tube. But I have to confess, apart from 1 or 2 kids that have more cure that we've dealt with, we've never had to resort to emergency intubation or a tracheostomy in a hurry. Infection, yes, it's not as common as one would think, I have to confess. Certainly, we've had very low infection through a transoral route. If you talk about infection from the back, we actually have very little infection, considering that a lot of our patients have tuberculosis of C1, C2 joint, and we are putting in implants. Not a great deal of infection, but if we have infection, the commonest reason why we have it is because the child is lying on the back and there is an erosion of the skin. They get an ulcer, and then the instrumentation just comes out through the skin. In that case also, most of the time I would try intravenous antibiotics, wash, even do a rotation flap rather than rush in to take out the implant. We would try and keep the implant if possible. We would only remove it as a last step. But I have had to do that. I mean, I've had a child where the child had a pressure erosion over the skin of the occiput. The entire area, it was eroded. The entire implant came out. And ultimately, we had to take out the implant and put the child on a halo and then do a graft, a skin graft, get the skin there. And in fact, we left the child on the halo and treated the child conservatively. But that's very, very rare.
Salomon, would you add something?
Well, the only thing I have to say is to congratulate Sandip for this outstanding lecture. It was really a fantastic one. You have such a way to explain that feel us very comfortable, even in my case, one who has no familiarity with cerebral vertebral junction problems. Just congratulations.
Thank you, Francisco.
We have a last question on the chat. Everyone are congratulating you. 2 questions about Chiari, one about treatment you already answered, Sandip, and the other is about physiopathology. If you agree with Goel theory that the Chiari malformation is caused by traumatic lesion and the syringe is a protective phenomenon. If you agree or not with this theory.
I've already answered that question. I definitely don't agree with that. Okay. I don't think that I would do that, what Atul recommends. You see, most importantly, that paper that he's published or what he shows, there is no control. So if he did a fixation on a group of patients and he did a decompression on another group and would able to compare and show us the difference, that would be understandable. But he's got 32 kids that he's, adults that he's fixed, and all of them have got better. And therefore, that's the ideal treatment. I think that's not very scientifically acceptable.
Okay.
Sergio, would you say something? I don't know if it's online.
Patricia, Junior? No. Okay.
Okay, I think that Borba, are you here?
I'm here.
Yes. Please, I think that we need to close this pediatric week, and please go ahead.
Okay, thank you. Thank you, Ricardo. Thank you, Nosi, Professor Salomão, Dr. Benicio, Artur, and all the pediatric team from Brazilian Neurosurgical Society and from around the world. Professor Sandip for the wonderful presentation. This is the 6th week of our educational program. In this pandemic, we try to do something, try to learn something, try to get something from this pandemic that's getting the whole world. the Brazilian Neurosurgical Society, I believe also the Mexican Neurosurgical Society and Latin American Neurosurgical Societies are proud and happy with this program. You continue in the next week. Next week will be the trauma session, and I will just show you here. Let me show here. You can see my screen?
Yes.
Yes.
You can see my screen, yes. This will be the 7th week. No, Professor Sandip, we start this with anatomy program just to have fun. It was 1 week. And the people was always saying that the peak's coming in the next week. And the peak never come. And now we're going. Next week you have trauma, and the other week you have again the neuro-oncology. You are going the whole world. This program, more than 5,000 participants in 6 weeks. In this pediatric week, you have 1,167 participants for 90 countries, 90, It's amazing. The number is increasing. And we are very happy and proud of this program because you have people like this Brazilian team, this pediatric Brazilian team, and all the Brazilian Neurosurgical and Mexico Society. I'd like to thank you, all of you, especially to you, Professor Sandip. Now it's 3 o'clock in the morning. Maybe it's not a time to sleep or to wake up, but thank you very, very much. See you everybody tomorrow morning for the anatomy day, and Monday, 6 p.m. for the trauma week for the Brazilian Neurosurgical Society and Mexican Neurosurgical Society. Thank you, all of you.
Thank you very much. Have a great weekend.
Obrigado aí. Valeu, foi
Ricardo,
super bom, hein, cara.
May I say
Ronaldo ali tá quieto ali, ó.
Can you tell something, Ricardo? Falou,
Yes.
Ronaldo.
Okay, thank you.
Thank you. Bye-bye.
Thank you very much. Bye-bye.
Thank you.
Bye-bye.
Bye-bye. Good. Have a nice weekend for everyone. Thank you, Professor Sandip, for
Thank
your
you.
great. Have a nice week.
And
Borba, sucesso, hein? Parabéns aí. Valeu.
Acho
Muito
que
bom.
ele vai ficar acordado até agora ali, pelo jeito. Ali,
You
3 horas.
stay awake with us, Sandip.
Ok. Então, Salomão, obrigado aí, valeu.
Thank
Tchau,
you.
tchau.
Thank you.
Bye-bye.
Welcome.
Thank you. Bye-bye.
Daqui 2 semanas nós vamos trazer um oncologista pediátrico do St. Jude lá. Chama Ibrahim.
Legal.
não sei quem é lá.
O Finley?
Hã?
Finley? Quem que é?
Não, lá do St. Jude. É o cara da...
St. Jude.
da
É o
oncologia
Parker.
pediátrica.
Deve ser o Parker.
Não, Ibrahim não sei de que.
Ah, tá ok.
Alguma coisa parecida com isso.
Beleza. Bom abraço. Paulinho, valeu.
Ok.
Tchau, tchau.
Valeu,
Um
obrigada.
abraço. Tchau. Valeu.
Tchau, tchau.
Thank you.
Tchau.